We asked the question whether carfilzomib, we have a prospective randomized trial comparing carfilzomib, Revlimid, Dexamethasone with carfilzomib, Thalidomide, Dexamethasone. Patients receive 9 cycles, and after 9 cycles, those patients are randomized to either carfilzomib maintenance therapy or control. The study is still enrolling patients, so we just analyzed both groups together and asked the question whether carfilzomib-based protocols overcome the negative impact of high-risk cytogenetics. And we created 2 groups with high risk, the so-called standard risk. These are patients with translocation 414 and deletion 17p. So standard high-risk patients. And then we had another group, extended high risk, which includes 414 translocations, deletion 17p, plus and or plus 1q21 amplification. So what we found is that patients treated with high-risk disease have similar outcome in terms of overall survival as compared to patients with standard risk. But progression-free survival was slightly impaired in patients with high-risk disease, defined by translocation of 414 and deletion 17p. And when we looked at those patients which had either these cytogenetic abnormalities and or amplification 1q21, then we compared this group with the group without these translocations or abnormalities, then we found a significant impairment in PFS. So, high risk, particularly when you include patients with amplification 1q21, is something which is only partly overcome by carfilzomib-based therapy. It doesn't impact on survival, but at this point of time, but it shows an impact on progression-free survival. Interestingly, when you look at overall response rates and CR rates, there was no difference. So the only difference was seen in terms of progression-free survival, which was short, slightly shorter in those with translocation 414 and deletion 17p, and was significantly shorter in those with translocation 414 and or deletion 17p and or 1q21. So carfilzomib is a good drug, but it doesn't overcome all risk situations in myeloma.